Chapter 7 Geriatric Considerations. By 2030, all baby boomers will be older than 65 years of age, and 82 million older adults are expected to still be alive in 2050. This is more than half of all older adults use at least one over the counter drug. And the administration of these drugs in the older adult population requires special attention to age related factors that influence everything from absorption, distribution, metabolism, and excretion. The physiologic changes would have effects on everything from reduction in total body water and lean body mass, reduction in kidney mass and function, reduction in liver mass and blood flow, postural hypotension with antihypertensives, volume depletion and electrolyte imbalance with diuretics, excessive bleeding with anticoagulants and antiplatelets, altered glycemic responses such as with anti-diabetic medications, and especially GI irritation with NSAIDs. When discussing pharmacokinetics in the elderly, pharmacologic processes have not received adequate study in the older adult population, and the understanding of pharmacokinetics is necessary for the safe administration of drugs in this population. Again, absorption, distribution, metabolism, and excretion can all be affected. When looking at pharmacodynamics, drug response is altered due to changes in the number of receptor sites, loss of sensitivity in the adrenergic receptors, blunting in the compensatory reflexes, reduction of dopaminergic and cholinergic receptors, neurons, as well as neural connections within the brain, and reduced blood flow to the brain itself. When looking at polypharmacy, the use of more medications than medically necessary, this is going to be a major problem, especially in the elderly, because not only do the elderly have a lot of chronic conditions that they can be juggling with, but they could also have multiple specialists, multiple pro- healthcare providers writing prescriptions for this one patient, and that med list can grow rapidly. And when that happens, you may run a major risk of having drug interactions. On our end, we want to make sure we have an accurate med reconciliation. We have an accurate account of everything that that patient's taking, and we can keeping that in one definitive record can go a long way in helping to avoid problems in the future. The elderly population run greater risks not only for adverse drug reactions, but also medication errors, therapeutic failures, adverse drug withdrawal events, and overdoses. Adherence is going to be another major issue, with the patient not fully understanding the drug regimen. Having a failure to adhere may cause underdosing or even overdosing. Medication education is also going to be extremely important for this population, as we want to go slow and we also want to implement that teach back method. That teach back method is something you're going to see a lot, and it is the best way to verify that a patient understands something. This is going to be especially true in the elderly population. It's also going to be something you see on NCLEX and ATI a lot. If it ever asks you what the best way to verify that a patient understands something, the answer is have them teach it back to you, have them demonstrate that they know it, have them provide a return demonstration. We also want to check sensory aids, make sure the patient has clean eyeglasses, and make sure that they functional hearing aids are in place. We want to speak in tones that the patient can hear. Avoid those high pitched tones. Try and speak in a lower pitched, calm, slow voice. Don't do it excessively so, but try to speak in a calm, slow voice. Make sure you're facing the patient so that they can see your face, see your reaction, see your lips. Try to limit distractions. You don't want to have a TV going in the background. You don't want to provide this in a hallway with a lot of other movement and noise around. Bring them to a quiet room where you can discuss and focus on the teaching. We want to use large print and bright colors anytime we're using visual diagrams or teaching aids. We also want to review every drug that that patient is taking at every visit. Instruct the patient to list all the drugs taken to all health appointments and encourage a simple dosing schedule. If a patient develops a new onset confusion, we want to start suspecting any recently prescribed drugs and encourage the patient to report if any new drug is ineffective. When assessing for cues, we want to assess for sensory and cognitive barriers. Also, looking at things like lab results, looking at kidney and liver function when we want to assess for polypharmacy or issues with excretion. Also, look at if the patient lives alone or do they have someone living with them who is able to help. Analyze cues and prioritize these hypotheses, and try to identify any potential dangers to the patient that could occur in the future. You also want to observe the patient for any adverse reactions when multiple drugs are taken at the same time, and recognize a change in any unusual behaviors or an increase in confusion. For our first practice question, which of the following does not cause frequent adverse reactions and drug interactions in older adults? Would that be A, the consumption of numerous drugs owing to multiple chronic illnesses? B, drugs ordered by several healthcare providers? C, increased action of the immune system? Or D, self medication with over the counter preparations? And that answer would be C, increased action of the immune system. Which of the following terms describes older adults taking many medications together? That be A, tachyphylaxis, B, drug interaction, C, polypharmacy, or D, tolerance? And that answer would be C, polypharmacy, which is a physiologic change seen in the older adult that has an effect on drug administration. That be A, lower gastric secretions, B, increased first pass effect through the liver, C, increased glomerular filtration rate, or D, lower cardiac output. And that answer would be D, lower cardiac output. Just like with anything else, as you get older, as these body systems and organs get older, they just don't work quite as well and effectively as they did when they were younger. And for our last question, when assessing older adults' renal function, which laboratory value will the nurse monitor? Would that be A, liver enzymes, B, serum electrolytes, C, complete blood counts, or D, the blood urea, nitrogen, and creatinine levels? And that answer is going to be D, BUN and creatinine. Again, as soon as you start suspecting any issues with the kidney, we want to start looking at that BUN creatinine, maybe a glomerular filtration rate. But that BUN and creatinine, especially, is going to indicate any damage that is occurring. But anyway, that's all we got for this chapter. I'll see you in the next slide.